For those of you who are joining us for the second, third, fourth, fifth time, welcome back. Great to see you again, and I've seen a lot of familiar names. For those of you who are joining us for the first time, amazing that you made it, and please do stay for additional sessions. We will come back. This is the last session this term. It's not the last session. We will be back next term. Now, it is my great pleasure to welcome Fiona Fowler, who has taken it upon herself to actually present at what is pretty much close to midnight her time. So she's coming to us from Australia, and she will be talking about HTLV1. I can see that this is the smallest session we've had so far, which will be great for discussion, but it also shows how hidden HTLV1 is, even among the hidden epidemics crowd. So hopefully Fiona will do a little bit about that. Without further ado, over to you, Fiona.
Yeah, thank you, Charlotte. And yeah, welcome everyone. Thanks for being here. Yeah, as Charlotte mentioned, I'm based in Australia, actually in central Australia, in an urban township called Alice Springs, which is right in the very middle of the country. It's a small town of about 24,000 people and surrounded by thousands of kilometres of arid land mass, remote desert country. And I'm a social worker and a research practitioner, I've been based here for a couple of years now. And I'm going to be talking to you about the obfuscation of the human T leukemia virus 1, also known as HTLV1, which is highly prevalent amongst remote Aboriginal populations in this region where I live and work. And I just want to acknowledge that this country on which I stand, it belongs to more than 500 remote Aboriginal communities representing 22 language groups and even more dialects. And some of these communities are as small as only a few people living on what we call outstations, often without electricity or adequate supply or clean water. And the ongoing processes of colonisation are very apparent in this context. And I guess that's something that sometimes people are not so aware of, that actually in Australia, a developed country that generally has a very high standard of living, we do have Aboriginal people living in conditions that could be likened to what is seen in more developing contexts. We have a disease burden that is considerably high here in Central Australia particularly, and a life expectancy gap of about 14 years between remote Aboriginal Australians and non-Aboriginal Australians. And Alice Springs, or Mbantua, where I'm currently situated, is owned by the Central Aranda tribes, and I do want to acknowledge and pay my respect to their elders, ancestors and leaders, past, present and emerging. So I came to HTLV1 quite serendipitously in 2018 when I was in Peru, which actually is another country where we find HTLV1 endemicity. And I'd left a social work position in my in the previous organisation that I worked, a federal government position, and I was pursuing some postgrad studies in Berlin, a master's in human rights. And my partner and I thought we would do a little bit of travel along the way. Not that South America is really en route from Australia to Berlin. And at that time, pre-COVID, it wasn't so outrageous. And we met while we were trekking, a middle-aged couple from Baltimore in the United States. And the male partner, Mo, he is an HIV researcher. And one night when we were sitting at dinner together, he asked me if I'd heard of HTLV1, and of course I hadn't. And he told me that HTLV1 was this virus, this incurable virus that was really prevalent amongst remote Aboriginal people in Central Australia. He asked me if I knew Alice Springs, and it was interesting to me at the time because I had been living on the east coast of Australia, but I had actually had this sort of immersive experience in Central Australia where I took up a social work position for 3 months and did what we call bush work. So going out bush, which is essentially a term that's used to refer to driving out hundreds, sometimes more than 1,000 kilometres to these remote communities and providing different types of services. And I'd done that for a really short period, only 3 months, but it had a huge impact on my worldview in a lot of ways. And I had thought about returning in a more meaningful capacity, perhaps. So this story about HTLV1 really piqued my interest because I thought, how is it that as someone who has some interest in Central Australia and in Aboriginal health, that I'd never actually heard about HTLV1, and since then the passion has really just developed and the work has eventuated, and I did end up looking at HTLV1 for my master's research. And what it led to was me returning to Australia in 2020 to carry out some field work where I was looking to explore perceptions toward HTLV1 in Central Australia. And what was supposed to be a fairly short fieldwork component of my master's research actually turned into a year-long project because COVID happened and I got stuck. And I also haven't left since then. I'm still here. Never went back to Berlin. And in this study, I spoke with Aboriginal community members and non-Aboriginal health professionals about what they thought about HTLV1. Did they even know about it? If they did, what did they know? How did they feel about it? Had they had experiences of health contact? What did they think about the intersection between HTLV1 and sexual and reproductive rights? And I'll talk a little bit more, obviously, in detail about that study. But I guess what it was the first of its kind. So not only was it the first qualitative HTLV1 study in Australia, but it was the first to seek the views of Aboriginal people whose communities are actually impacted by this virus. And it joins with a small body or movement of qualitative HTLV1 literature, which is mostly coming out of Brazil, where researchers are seeking to understand the patient experience and doing so largely through oral history methods, in-depth interviews and discussion with carriers and their families. So in Central Australia, we have the highest regional adult prevalence of HTLV1 in the world. The community-based prevalence of HTLV1 here is 39%. Amongst adults over the age of 17. And this figure was ascertained through a sero survey with 7 remote Aboriginal communities that was carried out by my colleague, Dr. Lloyd Einsiedel. And it was this data that sort of was stirring things a little back in 2018 when I met Mo. And actually at the time, a group of delegates from all over the world had written an open letter to the World Health Organization asking that they really look more seriously at HTLV1 and at developing an international public health response. So today I'll be sharing some of the findings of that study with you. And I guess in this study, what we've really started to do is to unpick why it is that HTLV1 is so hidden in Central Australia. The virus was first discovered here in 1988. The endemicity of HTLV1 to Central Australia was confirmed in 1992. And since then, we haven't had a systematic public health response, despite seeing such responses in other similar developed nations, such as Japan. And the prevalence that we have here is so high that it's difficult to ignore, and yet it is. And there are a lot of things that are ignored or hidden in Central Australia, and a lot of that has to do with those ongoing colonial processes that I mentioned. But we are also exceedingly geographically isolated. And there are interesting cultures that develop in a place like this, where you have a predominantly non-Aboriginal population that derives from the middle class, servicing a socially disadvantaged Aboriginal population. And that's something that, I guess looking at things through that lens was something that I was really trying to do with this work. So I'm going to outline some of the hypotheses that Dr. Einsiedel and I have developed around this neglect, in addition to sharing with you some of the historiography that I'm sort of trying to piece together around this issue. And I guess I also want to just say from the outset that I'm very happy to go slowly and for this to be a more interactive presentation. So from my perspective, it's totally okay if you unmute yourself and want to ask a question. But I will just note that this talk is being recorded. So if you were to do that, your contributions would be included in the recording. And if you'd prefer for that not to happen, then best to wait to the end. But please feel free to do that. And Freya, who's a bit more familiar with my work, you're very welcome to butt in and tell me about all the things I'm forgetting to say. All right, so HTLV1 is a human retrovirus. It's come about, or it does come about, through multiple episodes of interspecies transmission with monkeys who have the simian T-cell leukemia virus 1. And what HTLV1 does is it compromises the body's adaptive immune system, causing an inflammatory response. So the virus targets, it proliferates, and it persists in the body's T cells. And it makes HTLV1 quite a treatment-resistant virus. So at this stage, we don't have any effective antiviral treatments. We don't have a vaccine, although there is a group of researchers in Melbourne, in Australia at least, that I know of who are really working towards creating a vaccine. There are no rapid diagnostics or biomarker assays that are suitable for use in a remote setting. And HTLV1 is the known etiological agent of two fatal diseases, so an aggressive and very rapidly fatal hematological malignancy called adult T-cell leukemia, which typically causes death within 12 months of onset. And also some more insidious neurological disorders, of which HAM, HTLV1 associated myelopathy, is the most recognised, but you might also hear HAM being referred to as tropical spastic parepsis. And the available data suggests that 1 to 5% of people infected with HTLV1 will develop one of these two fatal diseases. So a relatively small number. However, there are a range of other clinically indicated conditions that do contribute to the HTLV1 disease burden. And these include inflammatory conditions like uveitis, eye disease, and infective dermatitis. And in Australia, where we have the C subtype of HTLV1, we've seen that high viral loads are very strongly associated with pulmonary disease, with HAPD, HTLV1 associated pulmonary disease. Unfortunately, lung disease is incredibly common in Central Australia, And so the many confounding factors associated with poverty, in particular the high burden of non-communicable diseases in this region, make it very difficult to, for example, exclude conditions like bronchiectasis and other pulmonary conditions at baseline. And this proves a challenge when we're wanting to demonstrate a causal link between HTLV1 and lung disease, as an example. Similar could be said for other disease entities that may be causally related to HTLV1. For instance, there's early evidence in Central Australia showing an association between HTLV1 and kidney disease, which again is a very significant contributor to the disease burden here. We have a rate of people receiving treatment for end-stage kidney disease in Central Australia that is 5 times higher than it is in the non-Aboriginal population. The reality actually for a lot of Aboriginal people in Central Australia is one where they have to come into Alice Springs off their homelands, off their country to receive dialysis and treatment for kidney disease. In Central Australia, hospital-based studies have shown that high HTLV1 profile or loads prospectively increase the risk of death for a person 3- to 4-fold. And HTLV1 seropositivity is associated with increased mortality in all endemic areas where this has been studied. And it's actually been shown to increase the risk of mortality in carriers by 57% independent of diagnoses of ATL or HAM. So while a lot of the literature has focused on those 2 fatal diseases with which HTLV1 is causally linked, it's becoming apparent that HTLV1 is a contributor to the disease burden in the populations that it affects beyond those two diseases. HTLV1 is distantly related to HIV, and this is a fact that has actually possibly contributed to its obfuscation and to the broader neglect of HTLV1 in research and in the scientific community. In the late 1970s, 2 research groups, one in Japan and one in America, co-discovered or independently discovered HTLV1 of one another. One of those groups, the American group, was led by Dr. Robert Gallo, and the Japanese group by Kiyoshi Takatsuki. And what both groups did was establish a relationship between HTLV1, between the retrovirus and the ATL malignancy. And this inspired the idea that AIDS might also be caused by a retrovirus, and subsequently led to the discovery of HIV. So amidst a burgeoning AIDS epidemic, HIV rapidly eclipsed this nascent attention to HTLV1, and it's a trajectory from which the HTLV1 research landscape is probably only just beginning to recover. So the dominant narratives at the time were that HIV was a higher risk to populations because it was more easily transmitted than HTLV1. HTLV1 requires cell-to-cell contact for successful transmission. HIV obviously has a high impact on mortality. More people were infected with HIV and also dying from AIDS. And these narratives then dominated subsequent knowledges that came about regarding HTLV1, which have, we could maybe say been somewhat suppressed. So for example, the finding that HTLV1 transmits more efficiently from a man to a woman than a woman to a man, which is one of the reasons that HTLV1 puts women at particular risk. The treatment resistant aspects of HTLV1 and its pathogenic potential, which I've partly described on this previous slide, but for which there is increasing evidence. And so the research trajectory around HTLV1, it never really stopped, but it was bedimmed, I guess you could say, by HIV. Importantly, though, HIV and HTLV1, they share the same transmission pathways. So HTLV1, like HIV, is transmitted sexually, so horizontally through condomless sexual intercourse, vertically through maternal transmission from a mother to a baby during breastfeeding, prolonged breastfeeding. There's been, particularly breastfeeding that extends beyond 6 months. There's been some Japanese research that has shown that the time between the 6th and the 7th month has been quite a crucial one in terms of transmission. But nevertheless, ideally, and particularly if the woman has a high proviral load, it's probably better and certainly lowest risk if she chooses not to breastfeed at all. And also, of course, HTLV1 is transmitted via blood contact, blood sharing practices, and donation and organ transplantation. So what has potentially been missed over time is an opportunity to borrow from successful HIV prevention campaigns to address the transmission of HTLV1 in affected communities. And this is something that was motioned towards actually by the Aboriginal participants in my study, who remember the HIV era in Central Australia very well, at least the older ones who were around at that time, because there was a real fear that HIV would spread very rapidly in Central Australia. And in fact, through some very grounded and grassroots initiatives, communities here in Central Australia were able to successfully avert the potential footprint that HIV could have had here, and we haven't had huge numbers of HIV in Central Australia through some of those initiatives. A second major contributor to the silence around HTLV1 is its occurrence in poor communities. So, as I spoke about earlier, Central Australian communities would fit that definition, being fairly marginalised and low socioeconomic communities located in the desert regions of Australia. An exception to this is perhaps Japan, although this is more a product. I mean, Japan is a very developed and wealthy nation, but the virus has actually migrated within Japan over the last decades, and it's spread throughout the country. And initially, it was discovered in a socially disadvantaged cohort of sex workers in the nation's southwest. HTLV1 is highly endemic to the Caribbean, to South America, Sub-Saharan Africa, and Oceania, including Central Australia, as you can see that tiny dot in the middle of the country. As you can also see on that map, there is endemicity in some of the Pacific islands, at least as far as we know. It could be present on more than just what's shown there, which I think is Papua New Guinea and maybe Vanuatu. What's been identified is that the strain of HTLV1, the C subtype, the one that's more highly associated with pulmonary vulnerabilities, is present both in Central Australia and in the Pacific, suggesting that actually HTLV1 has been around here for a very, very long time, and that possibly it dates back to a time when Australia was still connected as a landmass with the Pacific Islands and with New Zealand. And so the theory that's been developed is that HTLV1 emerged in the tropics of Southeast Asia, and then through these ancient migratory patterns, it moved down into Central Australia, and then has remained fairly isolated within Central Australia because of the geography of the region, but also because it occurs in these incredibly remote communities where people don't necessarily travel to or visit or move to other parts of Australia. There's also prevalence, which is lower, but still abiding in southern India, in Romania, in parts of China and Iran. And this map has estimated the number of infected people in each region based on available epidemiological data. And using that data, the authors Antoine Gassin and Olivier Cassar estimated that 5 to 10 million people across the world are living with HTLV1. So this is the most commonly used estimate of the global burden of HTLV1 infection, although it has been pointed out by others that we really only have epi data for about 1/6 of the global population, and that 20 million is probably a better estimate when we consider a few things such as access to testing. It's likely that the figures coming from the African continent are underrepresented, for example. And also, when we consider this ongoing debate that is happening in a number of countries, particularly developed countries, around the value or the cost effectiveness of universal screening for HTLV1 among blood donors. And I actually believe this has been ceased now in some developed countries. So that does obscure the data somewhat, or I guess reduce the opportunities for us to have a good understanding of HTLV1 prevalence at that kind of nationwide scale. So if we sort of zone into this map of Australia, which is definitely not to scale, but importantly shows you the region that Central Australia, or the regions that Central Australia represents. So those shaded sections are Central Australia. And as you can see, Central Australia is not just a part of the Northern Territory, but it's actually a tri-state area that extends into Western Australia and into South Australia. And the total size of the region is about 500 million square kilometres of spectacular and often impassable desert terrain. And what's important to know is that this entire region is serviced by one regional hospital, which is based here in Alice Springs, which I think from memory has only 193 beds. And apart from that, you've sort of got some satellite clinics in larger remote communities where maybe there are a couple of nurses who work there, generally agency nurses, so impermanent nurses who might fly in, fly out, and who probably don't have a primary care physician stationed at that clinic, or they rarely would, or they might for some months at a time, depending on availability. So primary care physicians will generally travel out to those larger communities, say once a month, and spend maybe a week there. But that's also dependent on whether they can reach those communities, if there are climate-related events, for example, or relating to COVID provisions, that service may occur via telehealth. And in terms of prevalence, it does appear to be higher in the southern and western parts of Central Australia that you see there. And then it reduces as we head up into the north of the Northern Territory, what we refer to as the top end. Back in 1992, when the endemicity of HTLV1 was confirmed in Central Australia, the prevalence rate that was recorded at that time was 14%. Now we have this community-based prevalence that was recently identified at 39%, but unfortunately, because of the large gap in studies that were conducted in between, it's quite difficult to prove whether the prevalence, or to understand whether the prevalence has increased over time. And these are all, ultimately sort of smaller serosurveys as well that we're working with. So I think it was in 2000 12 that the prevalence of HTLV1 in the north of the Northern Territory was recorded at 2.2%, so significantly lower than in Central Australia. And in the rest of the country, the prevalence is very low, less than 1%. One region that I will just point out, which is not actually, I haven't represented here. I did have an arrow, but it seems to have disappeared off my picture. I've written up in the top left, I've referred to the Kimberley, and the Kimberley is another remote region that is sort of located above the Ngundarra lands. And back in 1988, it was determined that there was a 15% prevalence in the Kimberley. But since then, that area is basically unstudied. We don't know what's going on with HTLV1 there. It's unlikely that without an HTLV1 public health response that this figure has reduced, this 15% prevalence. One pathologist who wrote actually the only PhD that's ever been written about HTLV1 in Australia, he published it in 1995, and I read it a couple of years ago, and I noted on one page in this PhD that he had actually planned some research with a couple of communities in the Kimberley that, for which he'd done some what seemed to be fairly genuine consultation. There was an Aboriginal liaison officer that was lined up to work on that study full time, and he was unable to obtain funding for it. And I did manage to get on to him and ask him about that experience, and his response was fairly simple, and that was that it was all about HIV at that time, and yeah, there wasn't a lot of opportunity to continue with HTLV1 research, and so he didn't. But yeah, because the Kimberley doesn't fall into that Central Australian region, it could be one of the reasons, I guess, why we haven't carried out any further research in that area. It's serviced by a different health service as well that's not located within Central Australia. So in the current prevalence data that we have for Central Australia is the 39% that I've mentioned a few times, which is the community-based prevalence based on data collected from 7 remote communities. The hospital-based studies have showed a slightly lower figure, but not drastically lower. And in both cohorts, both the community cohorts and the hospital cohorts, the prevalence seems to approach 50% in participants or patients who are aged 45 or older. The prevalence amongst children, not that children haven't really been a focus of the studies, but it has been low, 3.5% in the community-based study and 1.3% in one hospital-based study. And this is an area that really does require further exploration. We don't have an understanding of the rates of breast milk transmission in Central Australia. And studies that have been carried out elsewhere, the transmission rates do vary quite considerably. It's been an ongoing or perhaps an intermittent discussion in the clinical setting in the hospital as to whether those studies are carried out and how. And it's quite challenging because there is a perception that Aboriginal women in Central Australia are already very burdened without A, having to participate in research, or B, having to think about HTLV1 and whether they're going to transmit that virus to their child. And that's something that, I'll talk a little bit more about when I share some of the findings of the study, but it is essentially a problematic view because it is denying Aboriginal women information about their health. I guess in some settings, reportable diseases data could be a more reliable avenue through which to understand prevalence rates of HTLV1. In remote Australia, the reliability about notifiable diseases or around notifiable diseases data is complicated by several factors. So HTLV1 as well as ATL and HAM, the two fatal diseases with which HTLV1 is associated, are notifiable conditions in the Northern Territory if they are identified through clinical processes, but not in South Australia and in Western Australia. And as you can see, Central Australia extends into both of those jurisdictions. And beyond that, testing for HTLV1 in Central Australia is not routinized, and it depends highly on the individual physician or the treating team seeing value in obtaining the HTLV status for a patient. There is some standardization of testing practices at Alice Springs Hospital. So patients who enter ICU, for example, they are theoretically tested for HTLV1. Patients who have bronchiectasis or perhaps where there is a diagnostic dilemma are more likely to be tested for HTLV1, certainly in the hospital setting, than they would be, say, in one of those satellite community clinics that I mentioned. But another thing to know is that there isn't just one health service in Central Australia. So the government health services are responsible for the hospital and for a large majority of the communities in Central Australia. But then we also have an Aboriginal medical service that is based in Alice Springs and services or provides primary health care to all Aboriginal people in Alice Springs, including people who are visiting from outside of Alice Springs. And then there are separate Aboriginal medical services that service the Nunandarra lands in Western Australia and the APY lands in South Australia. And none of those four health services utilise the same systems. So continuity of care can become quite difficult when information is not easily shared or accessible between the health services. And so these factors considerably obscure the official case number data that is provided by the CDC in the Northern Territory around HTLV1 notifications. So in 2018, the director of the CDC reported that there had been 1,200 HTLV1 notifications since 1994, and that the rates of notification ranged between 20 and 120 notifications per year. Most of those notifications were coming from Alice Springs Hospital. So some people who live in South Australia or Western Australia would have been represented if they had been flown in and admitted to Alice Springs, or they'd been staying in Alice Springs and ended up in the hospital. But if patients who live on the Nunandarra lands or the APY lands are medevaced to another urban centre, which can also happen, such as Perth or Adelaide, and admitted to a hospital there, then they probably wouldn't be tested for HTLV1, and if they were, there wouldn't be a requirement to notify the status to the CDC and the NT. I guess the other thing to think about is that HTLV1 is something that is still universally screened for amongst blood donors in Australia, although this is also under discussion as to whether that should continue based on the cost benefit. But blood donation is relatively uncommon in Central Australia, and this is possibly related to some of the cultural meanings that are ascribed to blood. So, for example, the use of blood in various cultural ceremonies around initiation, healing, grieving, and other forms of cultural continuity. And I will note that exploring this further really requires sensitive and reciprocal research with Aboriginal people who have the authority to speak about such things. But it does limit how many people donate blood here. And there are also limited opportunities for people to donate outside of Alice Springs. If someone's living in a remote Aboriginal community, they wouldn't have that opportunity. So I guess the glaring question is around obfuscation and why there has been no public health response to HTLV1. Now, when HTLV1 was discovered in 1988 in Central Australia, it was very controversial. And that was because the studies that came about drew on sero data that had been collected more than a decade prior in the Kimberley, that region that I mentioned before. Data that had been collected in 1977, blood data from Aboriginal people for other purposes, and from whom consent was not sought to then look at those sero samples to determine whether HTLV1 was occurring in that population. And select health professionals and also one of the Aboriginal medical services publicly raised concerns about this at the time, and the ethical questions that this raised. But the researchers, who were a group of virologists from Melbourne, they continued with the study, and they actually added further retrospective sero data from hospital patients that had also been collected without their consent in 1984 and again in 1986. So the landscape was fairly troubled at the time around this new virus that wasn't actually new, and what it meant, and why it even was that we were looking at it, and how we white people were examining Aboriginal populations to see whether this, I think exotic was the word that was used, whether this exotic virus was present in Central Australia. In 1992, Ivan Bastian and his team confirmed the endemicity of HTLV1 to Central Australia, although the ethical concerns that had been raised around the former study weren't really addressed by that research either. And this is an excerpt that I've pulled out of the CARPA newsletter from 1989, the Central Australian Rural Practitioners Association newsletter, which sort of sums up the controversy at the time. I've tried to locate some of the media articles that were published around this time, and I have managed to find a few. And it wasn't so much that the media mistook HTLV1 for AIDS, but a very close link was drawn between the two. And most of the headlines contained both HTLV1 and AIDS in them, or if not AIDS, HIV. So this presumably led to some misunderstanding and distress in the community at the time, because people were fearful of HIV. And HIV was very visible, at least in public discussion and in public health, and also in practitioner-patient interactions, which HTLV1 certainly wasn't and still isn't. So following on from this, there were a range of reasons that were publicly given not to continue with HTLV1 research or initiative in Central Australia. And the predominant sentiment was that there was this absolute need for consultation with Aboriginal communities, and if possible through the Aboriginal medical services. But no plans were actually put in place for this to occur. And so we did sort of see the research or the movement towards action quite markedly halt at that time. Another reason that was given, I guess, not to continue with the investigation into HTLV1 was the long latency period before the development of clinically recognised HTLV1 diseases. So ATL, for example, if it does develop in a carrier, this usually happens 30 to 40 years after the person is first infected with HTLV1. The latency period is somewhat shorter for HAM, but it has more of an insidious onset, and there are diagnostic challenges which can mean that it's not identified at the time of onset. And the kind of sentiment, and it wasn't even unsaid actually, it was very explicitly said, was that because it took so long for these diseases to develop, and because ultimately they only developed in a very small percentage of carriers, which we now know is between 1% and 5%, that Aboriginal people with their low life expectancy, which was even lower then than it is now, were more likely to die of something else before they would die from an HTLV1 associated disease. The C subtype was also said to, I don't think it had been identified as the C subtype as such at that point, but certainly it was recognised that it was a different strain here to the cosmopolitan strain that we see overseas, say in South America, for example. And it was purported that strain was not going to cause the disease and death that HTLV1 was causing overseas. Then, of course, the first reported case of ATL, one of the fatal diseases in Central Australia, came about in 1991, and the first reported case of HAM 2 years later in 1993. Kind of overall, there was this perception that Aboriginal people are already burdened, that conditions of poverty and all of the associated disadvantage with that were very present, and that because of that, HTLV1 was unlikely to be of priority to Aboriginal communities. And these were claims that were made mostly by non-Aboriginal people, speaking on behalf of those communities who would not have been informed about HTLV1 at that time. And the same individual spoke about the complexities of navigating cultural sensitivities related to addressing transmission. So the meaning of blood, for example, which I touched on before, that could make those discussions particularly sensitive with Aboriginal people. The health risks associated with advocated weaning or with not breastfeeding at all, and the knowledge that Aboriginal women can breastfeed for very long periods. Yeah, that's something that is, it hasn't been recorded very well, but anecdotally and observationally, some women do breastfeed into a child's third, fourth, fifth, sixth birth year. And then the challenges and gender sensitivities that were already being experienced around addressing sexual health in a population with a high level of STIs. So all of these views were expressed in the academic commentary at the time, and 4 decades later, when I started to carry out this research, all of the same arguments were put forward by health professionals that I interviewed for my study in 2020. And I'll just let you read some more primary sources that I've pulled out, which sort of demonstrate some of these arguments that were given. So I guess in that top left one, you can see there's that narrative around the HTLV1 that's found in Australia not actually being harmful, that it's different to the strain that's been identified overseas. And then bottom right is that really overt assertion that, yeah, people are probably going to die of something else. And what is the value of talking about HTLV1 if that's the case? And I've referenced the bodies of literature from which these primary sources derived, but in the interest of preserving the anonymity of the writers, at least at this stage, I haven't included the names of the authors. Some of those people are definitely still around. And I've just, there are just a few more here, which you can have a read through. So, as I've said, all of the themes that arise in these excerpts, they also arose in the qualitative study. So this questioning of the value of a public health initiative around HTLV1, the notion that Aboriginal people are already dealing with enough, they're already burdened by ill health, and that HTLV1 is unlikely to be as important to them as other diseases that they might experience. This emphasis on poverty and socioeconomic disadvantages overwhelming the possibility or the need to address HTLV1. There's a bit of clinical nihilism around what can actually change. And on a slightly different note, as you'll see in that very first excerpt, Aboriginal people's perceptions toward surveillance systems and how blood is stored and used for research purposes. And we obviously, we got off on the wrong foot here back in the late 80s or the early 90s, because the research community was really silenced at that time with regards to HTLV1. And there was actually quite a significant gap of about 10 years where there was sort of no research initiative until Dr. Einsiedel started working at Alice Springs Hospital, I think around 2005. And I think it's also important to note that the views that I've just presented in these primary sources, they do largely belong to non-Aboriginal medical professionals that belong to a very different social class to the patient population. And that with the exception of one of them, the people who are speaking are not consultant physicians, and they don't necessarily have specific infectious diseases expertise. They're primary care physicians, reporting on their clinical experience where they're not necessarily looking for HTLV1. And secondly, it should be noted that the idea that Aboriginal controlled health services, we call them ARCHOs here, should be consulted regarding HTLV1 is valid, but it needs to be remembered that these services also have very few, if any, Aboriginal doctors. They do often have sort of other groups of Aboriginal staff that maybe work on health promotion. So there's opportunity there with the right support for people to be trained in providing education about HTLV1. But these medical services, these Aboriginal medical services, they don't have the capacity to carry out direct consultations with the communities that they serve, and they're more likely to rely on consultation with a few key community leaders and not necessarily be speaking with whole communities. So in terms of approaching this research in a community-based manner, it's possibly actually better to work around the health services and with the health services, talking to the communities directly. Working with the ARCHOs is not necessarily the only or the best pathway. The research study in 2020, it seems like that text is very small, apologies. What I was trying to do with that study was respond to this paucity of Aboriginal voices in the historiography some of which I just shared with you. And so one of the aims of the research was to prioritise Aboriginal voices. I was operating from a decolonising perspective or theoretical framework, and to actually emplace some of the knowledges about HTLV1 back with Aboriginal people, which in Central Australia is where it belongs, because Aboriginal people are those that are impacted by the virus. And so I carried out this study because, as I mentioned before, I got stuck here with COVID, so I tripled my intended sample size of 20 participants to 59. And most of these interviews were carried out in Alice Springs. However, additional to that, I was able to develop a relationship with one very remote Aboriginal community. A fairly small Aboriginal community has an estimated resident population of 140, adult resident population of 140 people. And so I think, there were 30 Aboriginal participants and 29 non-Aboriginal health professionals who participated. And 9 of the interviews were carried out in this remote community, sitting in the dust on the arid lands at the edge of the Simpson Desert. The interviews were largely unstructured. There were 36 individual interviews, 5 group interviews. And in terms of the health professions, 4 nurses participated, 7 midwives, 13 doctors, 8 of whom were primary care physicians and 5 of whom were specialist physicians based at the hospital, and additional to that, there were also 2 hospital-based social workers who took part and 3 community workers who were based in an NGO that provided health promotion or carried out health promotion activities in the community. I don't need to really go into more of the specifics. It's sort of listed there. But what I will mention is that initially I hadn't intended to interview Aboriginal men because of some of the cultural and gender considerations that need to be had around that. But interestingly, when I was in the remote community, I was approached by 3 men who requested to participate in the study. And those interviews were particularly rich, and I'm very grateful for that experience, and that those men were willing to see past, I guess, some of the gender norms and boldly speak to me about HTLV1. All of the participants had a fair command of English, and with the exception of one woman, they chose not to use interpreter services, which was interesting because it's a difficult topic, and yet they wanted to talk about it in English. That's something that possibly could be explored further. But I do acknowledge that I possibly would have obtained a richer narrative, and even richer narrative still, if I were to have a local tongue. And there was some remuneration offered as well to participants through a small gender equity grant that I was awarded by the Northern Territory government. So the aim of the study was to explore people's perceptions. I think I talked about this earlier, what people know and think about HTLV1, what their experiences of health contact have been for the patient cohort anyway, or the community cohort, I should say. And also the interface of HTLV1 with sexual and reproductive health. And obviously it was a very different experience to interview Aboriginal people than it was to interview non-Aboriginal participants from the health professions. And due to the protracted obfuscation of HTLV1 in Central Australia, it was expected that awareness amongst the Aboriginal cohort would be low, and also that the interview content may cause distress for people as they potentially learn about this highly prevalent and potentially fatal virus for the first time. So responding to some of those sensitivities, a flipbook was developed using images from a video that was made for the community-based prevalence study in 2018. And this flipbook, from which you can see one page here on the slide, was used to facilitate the interviews with Aboriginal people and act as a visual reference point for the discussion of complex ideas around transmission, treatment, and clinical associations. So of the 30 Aboriginal participants, only 8 had previously heard of HTLV1. Several had participated in the community-based prevalence study, and that's because the remote community that I mentioned that I visited and interviewed a few community members from, that community had participated in that previous prevalence study, and that was done very intentionally to, I guess, sort of, continue this story of HTLV1 in that community, and also because the purpose of the study was not to provide education, and so I guess there was a higher likelihood that people in that community would have some idea of what HTLV1 was from those years ago. Sorry, I just noticed that there were questions in the chat, and I just wanted to double check that there weren't any directed to me. Others who knew about HTLV1 had provided cultural brokerage for that community-based study. There was also a participant who disclosed their positive status and their understanding of HTLV1 and shared what that meant for them and for how they think about their health. And one had read about the virus in 2018 when there was a little bit more media publicity in Australia and internationally about HTLV1. I think they'd read something on Facebook. So this figure I've actually pulled out of the manuscript that about this study that's currently awaiting publication. And it's a little bit dense, but it does sort of broadly summarize the 4 themes, I guess, that were pulled out of this study. And the first one was, or I guess maybe the most alarming one, was some of the assumptions that were voiced about Aboriginal people by non-Aboriginal health professionals. And these were around ideas that the complexities of HTLV1 would not be well understood by Aboriginal people, that providing information about an untreatable disease could be harmful or fear-provoking. And actually some of the health professionals admitted to avoiding discussing HTLV1 with Aboriginal patients for this reason. For the same reason, clinicians avoid testing. And that is because to explain the virus, what it is, the disease process, the natural history of HTLV1, to explain the reasons for testing, and in particular, the reasons for testing for a virus that has no treatment, was seen to be too challenging with the language and cultural barriers, and also with essentially what is a racist view around how well this information would be comprehended by Aboriginal people. And I do want to say that the cultural complexities associated with working in Central Australia are huge, and it can be very difficult to communicate effectively. And I think a lot of the time us white folk are operating very much on the edge of effective communication, and certainly interpreter services are astoundingly underutilised, particularly in the health setting. But I guess what we noticed in this study was that some participants were more willing, or have been more willing, to enter into those conversations about HTLV1, to find a way to talk about it, to draw on their experience of cross-cultural health practice, and and to maybe find creative or more visual ways of communicating what are complex ideas. The second sort of topic, or can you still hear me? Can you still hear me? I've just been told that my internet connection is unstable.
We can hear you again. You were gone for half a second, so we didn't lose any content.
Okay. All right. No worries. Thanks, Charlotte. The clinical perceptions that HTLV1 is not a significant virus. So the notion that there are not enough people dying of ATL or HAM, and also that the causal link between HTLV1 and other associated diseases are not clear enough to warrant a public health response, and potentially, for some participants, not clear enough to warrant having those discussions in the clinic with someone, offering somebody a test, considering whether a test might be worthwhile if there is a diagnostic mystery. Some participants referred to Bradford Hill criteria, which is interesting. Dr. Einsiedel and I have looked at the studies available around HTLV1 in Central Australia, and our assessment is that they actually meet 8 of the 9 Bradford Hill criteria around demonstrating causality for pulmonary disease and HTLV1, a causal link between those two. Curiously, the non-Aboriginal cohort, or some of the non-Aboriginal cohort, made these contributions around HTLV1 not being a clinically significant virus, whilst also admitting that they hadn't read a lot or read widely about HTLV1, including, for example, some of the more recent and pertinent studies around pulmonary vulnerabilities and how they're connected with HTLV1. We also noted a difference in perceptions between hospital specialists and primary care physicians, where the former were more likely to acknowledge the harmful impacts of the virus and to notice, observe, and look out for HTLV1 in their clinical work. The primary care physicians, with the exception of a few, were not necessarily looking for HTLV1 as a possible contributor to disease, and not necessarily referring prospective mothers where the HTLV status was known, a positive status was known, to the hospital, to the infectious diseases department for an assessment of proviral loads or to obtain some more tailored breastfeeding advice, which is something that infectious diseases at Alice Springs Hospital does offer. There were ethical concerns that became very apparent in this study. Firstly, that clinicians were disregarding existing guidelines that are already in place around providing advice to breastfeeding positive mothers. And I'll show you some of the quotes around that in the coming slides. The neglect to test or to share HTLV1 information with patients was sort of insisted upon, with little consideration that sharing information about HTLV1 might reduce transmission to family members or sexual partners, or give the patient kind of any sort of agency over the disease process. And particularly among the primary care physicians, HTLV1 was sort of pitched against what is called the core work. So that's the non-communicable disease entities, diabetes, heart and kidney disease, which are very, very prevalent in this context. And then, finally, there's just a sort of a short summary here around some of the concerns that were voiced by Aboriginal people. So the socioeconomic realities of being able to access safe and clean breastfeeding alternatives, or even being able to access breastfeeding alternatives at all in a remote community. What was actually possible in this remote setting in that regard. Clearly, there was a great concern that HTLV1 knowledges had not previously been shared with them or with their families or communities. And as I stated earlier, several did reference the HIV era in regards to this. And, you know, why HTLV1, which is a longer standing infection here, is not known. But there was a real emphasis on HIV at the time when HTLV1 was discovered. And Aboriginal people did also talk about some of those cultural and gender sensitivities regarding the modes of transmission. So sexual transmission, blood contact, and breastfeeding. So very difficult to do in over 52 hours of interview, or with over 52 hours of interview data, but I've just included some of the quotes here, which I'll let you read. I think they do really speak for themselves. So the clinical perceptions of the primary care physicians, and there were some primary care physicians that do have a different practice than what's reflected here. I do want to acknowledge that. But largely amongst that group, there was a low value placed on a decision to include HTLV1 in testing, in routine testing, for example, or in patient management more broadly. And additional to the communication barriers and also the assumptions about Aboriginal people that I've already mentioned, the outcomes and natural history of HTLV1 are still quite unclear was a fundamental deterrent for primary care physicians who are dealing with a lot of other disease entities in their practice, often with very little time in consultations. So to go into the story of HTLV1 is perceived to be quite challenging and potentially not worthwhile. Now, there was only one primary care physician who was able to describe a consistent practice of sharing HTLV1 diagnosis. And this was the only doctor who had really ventured down a path of HTLV1 engagement with her patient cohort. That doctor also had a very small patient cohort in which there had been a case of ATL and HAM, and was finding that particularly significant, that she was coming across sort of a number of diagnostic dilemmas, and then wondering whether maybe it could be HTLV, referring those people to infectious diseases, and then finding that they're positive. And so she had developed a bit of a way of talking to people about it, but expressed the same frustrations around not being able to offer a treatment, not being able to talk in numbers about what the risk of developing a disease actually is for a person. Helping people to explore further pathways, get further testing, but they're not necessarily getting anywhere with that. There was no acknowledgement by any other medical practitioners, whether specialists or primary care physicians, that a person being informed of HTLV1 or being offered an opportunity to know their status may have positive implications in terms of reducing transmission, or by allowing that person to have some control in their health management. The tension between sharing HTLV1 information and the need to promote breastfeeding very clearly preoccupied maternal health care professionals. Recognising the importance of breastfeeding to infants in remote Aboriginal communities, there are guidelines that have been developed at the hospital that recommend individualised management of HTLV1 infected mothers according to her social circumstances and also her family's ability to provide safe alternatives to breast milk. But regardless of that, the acceptance of those guidelines appears to be low. I mean, yeah, you can see in the first, in that first quote, that there is a real resistance to talking about stopping breastfeeding at all, particularly with how far, I guess, we've come in Central Australia with that. And obviously breast milk is very protective in terms of preventing other diseases. And these considerations that were made by maternal health professionals were inextricably tied up in the controversy around testing. Because HTLV1 testing has been included in routine antenatal screening programs in other countries such as Brazil and, as Japan and increasingly in Brazil, this has been an ongoing discussion even in Central Australia. And actually one participant who worked in health promotion had developed an education package about HTLV1 for remote clinicians that was not approved because of its reference to breast milk transmission and successful initiatives around this in other countries. And even though there are these guidelines at the hospital, there is an ethical dilemma in that the status is not known. The HTLV1 status is not known for a lot of women, and routine testing is not yet supported. And so for women who've been opportunistically tested in the past, and for whom we know there is a positive status, they have the opportunity to receive that further specialised advice from infectious diseases. Other women who haven't been opportunistically tested won't have that opportunity, but may still be carrying HTLV1 and have a high proviral load and have a child who's at risk of contracting HTLV1. And moving on, I guess, to the most important part of this study, which was about seeing and hearing the voices of Aboriginal participants. I've pulled out some of the direct quotes. And Aboriginal people were very concerned that there had been no attempt to provide their communities with knowledge about this lifelong infection. And this fellow, I want to say that for some of us that could be late. You know, we might have already got infected, which is a shame. Like now talking to you, and before I get my blood and I wait for my result and I find that I have it, you know, it's just going to turn my world upside down. That's when I'm going to worry about my partner and my kids, you know. What if they have it too, and my grandchild? As I mentioned before, there was this comparison with a stronger approach to HIV, and that was questioned by Aboriginal participants, knowing and hearing about AIDS, but not knowing that there was another disease that was actually more prevalent and still is. More than a third of the participants, both Aboriginal and non-Aboriginal, remarked that a virus infecting a different Australian population with a similar intensity would elicit a more compassionate and a more immediate response. And this participant in particular really drew attention to that question around who's responsible, both for withholding information around HTLV1 and now moving to a place where we try to remediate that. And in the remote community, these discussions about HTLV1 assumed a still more personal nature, as the participants reflected on the death of a community member due to ATL. So these participants, or these community members, they wouldn't have necessarily known that this person that they refer to who'd passed away, one of their family members, they wouldn't have necessarily known that the thing that that person had was called HTLV1, but there was some awareness. They had a blood cancer. They died from ATL. And so when we started talking about the virus and going through that flip book, there was this recognition that this is what this person had. Deaths resulting from ATL are uncommon, but I guess what these narratives revealed was the profound psychological impact that such a loss can have on the surviving residents of a small remote community of 140 people. And I interviewed 10 members of that remote community, and 7 of those participants voiced concerns about HTLV1 in the context of this death, of the death of this person, including these fears, which we read before, that they or their relatives might also be infected. And there was a consensus that the health and the economic and social consequences of reduced breastfeeding do need to be weighed against the risks of HTLV1, as is the case in other resource poor settings. And this quote really encapsulates, I guess, the fiscal reality of living in a remote community where survival is the everyday. There's not a lot of employment available. A high proportion of community residents will be welfare dependent. And because of the remoteness of these settlements, the price of food and really anything that can be purchased at the one community store is incredibly inflated. And of course, businesses do take advantage of that as well. And something that's touched on in this quote as well is the issue of overcrowding. So how many people are living in one house? And what does that mean? What does that mean in terms of, the emphasis on something like HTLV1 when the day-to-day can be so strained and so uncertain? And I guess kind of on the flip side of that was that amidst all of this fear that was expressed, particularly among the non-Aboriginal health professionals around adding to the burden that's already experienced by Aboriginal mothers, in this context, there's actually this remarkable story or confidence that emerged from the Aboriginal women that I interviewed around the capacity of women to manage the risk that might be posed when it comes to breastfeeding children in the community. And so this, is just a really lovely kind of piece of that, that we would adapt, we would help each other. And there's so much more to kind of be understood here around, family and kin relationships, also skin relationships, which is a kind of a network concept within Aboriginal communities, how people relate to one another, what roles and responsibilities people occupy. Wet nursing was also something that was raised around women who are breastfeeding the children of other women who have HTLV1. Breast milk donation was also something that came up. So all potential strategies, community-oriented strategies that that could be delved into and that could be potentially trialled if done so in a supportive and a culturally safe manner. And so overall, there was this consistent articulation from Aboriginal people that they and their communities would like more access to and can hold knowledges about HTLV1. And this finding really controverted the perceptions of the healthcare professionals that the complexities of HTLV1 would not be well understood, or that sharing knowledges might overwhelm Aboriginal people. And so I'm not going to delve too much in, I'm about to sort of finish, and I would really love to start the discussion. And I'm not going to go too far into the suggestions for a public health response, but there certainly was an imagined sense of action that, that came about during these interviews. And this was really about having a clear clinical pathway, both for carriers, so clear referral pathways, and health management models for people who have HTLV1, and to support the health professionals who are working with a population in which HTLV1 is hyperendemic. And having this robust clinical approach occur alongside education to empower and equip Aboriginal communities to participate in and ideally to lead potential HTLV1 initiatives in Central Australia. So some of the suggestions were around the use of visual aids, in having discussions in talking through treatment options, or preventative options, I should say, because a treatment isn't available. Having an untroubled physical space in which knowledges are shared. Yeah, potentially even having those conversations outside of a clinical setting. And I'll talk a bit more about that in the next slide. And encouraging a shared ownership of HTLV1 knowledges between clinicians and patients. So all in all, this sort of slow action of consciousness raising. I think, yeah, one of the participants said the idea that it's like yeast and it might actually make the dough rise. And of course, the emphasis must be on translating HTLV1 knowledges in a culturally safe way. And I just want to end with a quick explanation of this idea of a wellbeing camp, which was actually a suggestion made by some of the remote community members. Both men and women suggested this. And that was to, yeah, have a camp, which is actually a really common practice both in and outside of the health arena, in Aboriginal communities, where people go out bush. I mean, they're already out bush in their communities, but they kind of go out bush again outside of, you know, the gates of the settlement, and spend time on country, and yeah, potentially talk about more difficult issues. And there was an idea that this could be done with communities as a way of introducing the idea of HTLV1 and getting some consensus or sense from the community around what they want to do about it, and how they want to address transmission in their patch. And it's a recognised practice in Aboriginal health. According to some of the older Aboriginal participants, it dates back to the HIV era that there were wellbeing camps being carried out about HIV. And integral to this coming together is the stipulation that it occurs in gender-separate groups, away from the community, and establishing the meeting as a protected space for important health discussions. And there was agreement that the transmission of HTLV1 via sex and via breastfeeding were appropriate discussion topics at these camps. So this is actually something we're looking at piloting, and recently have been able to get some funding to carry out a wellbeing camp with the women in the remote community that participated in this study. So we're looking at doing that at some point this year, and we'll be writing about that, and also probably making a video after the camp where some of the women, if they feel comfortable, can share some reflections, and that video can then be used to raise awareness and potentially as an advocacy tool. Just got some references to some of the images in this presentation, and that's sort of it from me. I totally did the thing where I talk and talk, but would be very happy to start a discussion, or take questions.